Dr. Fazal, what would you consider your current standard of care treatment for blastic plasmacytoid dendritic cell neoplasm?
So thankfully for the blastic plasmacytoid dendritic neoplasm, we can call it BPDCN for the rest of our presentation. Historically for BPDCN, chemotherapy has been the backbone of most of the treatments. And in the past, we have used both AML and ALL-like regimens in patients in treatment of BPDCN. However, as you can imagine, those AML or ALL-like regimens cannot be used for majority of patients. So when I am assessing a patient with BPDCN, I'm assessing whether or not patients are fit or frail. So usually my treatment algorithm follows that assessment initially. I would assess if the patients are fit. I would consider two options, either using the tagraxofus, which is the newly drug therapy, which has been approved by FDA for treatment of BPDCN. The other option would be to use intensive chemotherapy, which, as I mentioned, that ALL-like regimens has been used in the past with success. However, although those do lead to a good response rate, the responses tend to be transient, and one has to follow those kind of regimens with allogeneic stem cell transplantation. Now, as I mentioned, that the treatment has been changed by the approval of tagraxofus, and we will talk about in detail about tagraxofus FDA approval. But for that matter, I would assess looking at the eligibility criteria for the patients that were enrolled in the clinical trial, and one of the major factor that played in terms of enrolling these patients was the serum albumin. So if the patient's serum albumin is less than 3.2, I would not consider using tagraxofus for those patients. The second factor that excluded patients for the treatment of tagraxofus was CNS involvement. So patients who have CNS involvement, again, one may not consider using tagraxofus unless someone wants to add CNS therapy along with the tagraxofus, which again has not been studied with that combination. For the frail patients, it is much more challenging because the median age of this disease is in late 60s. So unfortunately, that could be a significant proportion of our patients that get evaluated. And for those patients, we may consider enrolling them on a clinical trial. For some patients who are very frail, we may consider just local therapy. And in that sense, radiation could be a useful modality just for cutaneous involvement. So we may consider just using radiation or steroids for those frail patients who are not candidate for tagraxofus or are not candidate for even any intensive chemotherapy. What do you think about the second-line therapy?
Well, and I view tagraxofus as the first-line therapy. I mean, I'm certainly old enough to remember when we used ALL-like regimens. We also occasionally used cytarabine and daunorubicin, an AML regimen, and our response rates were not particularly good. I think you're right the way that you framed it, looking at eligibility criteria for the clinical trial, and those who fall outside the eligibility criteria are in some ways conferred upon them is conferred a need for another therapy, and you have no choice but to go back to something older. On the other hand, patients who have had an initial response to tagraxofus, either alone or after allogeneic transplant who sustain relapse, again, are potential candidates for an ALL-like regimen. But response rates are not particularly good and survival is not particularly long. And so I think that your best chance is when you're treating patients initially. If they've never been exposed to the monoclonal antibody and have achieved a remission to a vincristine-based regimen followed by allotransplant, well then of course, yes, you would use tagraxofus in the second-line setting. But in the first line setting, I think it would be better to go with the novel agent. It has a specific indication, and again, the alternatives are not particularly desirable.